presented to our unit, followed by net on a case on a study we have run on HLH example. A 2-year-old male patient admitted to our hospital. 2-year-old male patient admitted to our hospital suffering from fever 2 weeks before hospital admission associated with cough and dyspnea. A patient diagnosed as having bacterial pneumonia according to laboratory and clinical findings. And although appropriate treatment, the condition had improved and he was still feverish, he has a past history of previous hospital admission at the age of 1 year with a similar condition. Positive data on review of systems, the patient was underbuilt with a body weight 10 kg below 3rd percentile. He was feverish and fine crepitation on both lung fields by examinations, and also abdominal examination showed hepatosplenomegaly, that's confirmed by ultrasonography. Investigation, his CBC showed pancytopenia with positive CRP and elevated procalcitonin. Common virology markers were negative, and bone marrow aspirate showed hypocellular bone marrow with reticulocytopenia. The general condition of the patient started to deteriorate with the elevated liver enzymes and started to be jaundiced, and this clinical with the laboratory findings, and after exclusion of infection and malignancy as a cause of his deterioration, we suggested HLH, and so we ordered the following investigation. Investigation ferritin level was highly elevated, above 5,000, and triglyceride also elevated above 500 with decreased fibrinogen, and natural killer cell activity was below 10%. A summary of the case: the patient had a history of prolonged fever with hepatosplenomegaly, and his lab showed pancytopenia with hyperferritinemia and hypertriglyceridemia, hypofibrinogenemia, and decreased natural killer cell activity. So the patient had about 6 of the 8 diagnostic criteria of HLH. So he was diagnosed as HLH and started a protocol of treatment with improvement of the general and clinical and laboratory condition. Our single center study about HLH. Briefly, HLH is considered as a hematological disease characterized by hemophagocytosis of RBCs with platelet and neutrophil by histiocyte, and the proliferation of T cell and histiocyte in the spleen, bone marrow, and the infiltration into body organs. The activated macrophages secrete large amounts of cytokine, which cause tissue damage and leads to organ failure. Hemophagocytosis, HLH, is classified into 2 major groups as genetic and acquired, or primary and secondary. And primary HLH includes about 9 subclasses. Familial HLH with its 5 classes, and HLH occur with Getiak-Higashi, or Griscelli syndrome, or lymphoproliferative disorder. Or acquired secondary, which occurs secondary to infection or malignancy or hematological disease. And the perforin gene mutation, which is considered the cause of familial HLH type 2, has a mutation more than 100 mutation with different subtypes, including missense, nonsense, and frame shift mutation, so I get deletion or insertion mutation. Diagnostic criteria of HLH occur by the presence of about 5 of the 8 following diagnostic criteria: fever, splenomegaly with or without hepatomegaly, cytopenia, at least by cytopenia, hypertriglyceridemia and or hypofibrinogenemia, and elevated serum ferritin level, and soluble CD 25% above 2,040 units per milliliter. Our natural killer cell activity decreased or absent with hemophagocytosis, either in bone marrow or other tissue. The aim of our study was to clinical characterization and perforin gene mutation detection of HLH cases in children at Zagazeg University Children's Hospital. It was observational cross-sectional study. Patient with HLH admitted during the study period throughout 1 year, 18 cases. The patient included in the study were who fulfill at least 5 of the 8 HLH diagnostic criteria. All cases that fulfill the inclusion criteria were subjected to history taking, examination and investigation, and genetic analysis to detect perforin gene mutation using DNA extraction, PCR amplification, cycle sequencing, and sequences were compared with the published perforin sequence and the gene bank with this accession number using Mega software. Our result, demographic data, the study showed that the age age of the patient ranged from 3 months to 12 years, with a median age of 2.2 years. According to gender, male represented 44% of them, and female for about 55%. According to diagnostic criteria of HLH, we found that all of our studied patients had a fever with hyperferritinemia, and about 80% of our patients had organomegaly, either splenomegaly or hepatomegaly with bicytopenias. And about half of patients had a high triglyceride level, and soluble CD25 was elevated in about 60%, and 22% of our patients had decreased or absent natural killer cell activity, and hemophagocytosis was presented in bone marrow in about 44% of our patients. And our study showed that 27% of patients diagnosed as secondary HLH as a result of concomitant viral infection, and the most common viral infection was Epstein-Barr virus, followed by cytomegalovirus and hepatitis B virus. Perforin gene mutation, for detection of perforin gene mutation after sequencing of a PCR product, we found a mutation in about 8 of 80 patients, about 44% of the patient tested, and interestingly, 9 previously unreported mutations which haven't been listed in the single nucleotide variant database were detected. And according to the genotype of the mutation, we found compound heterozygous mutation and homozygous and heterozygous mutation by this percentage. And according to subtype of mutation, we detect a silent and missense and frame shift mutation with this percentage. And this table shows a molecular characterization of perforin deficient patient according to type of mutation and protein changes with site of mutation and durability with the outcome of patient. And the overall outcome of the patient was that in about 70% of our patients died, and about 27% is still alive at the last follow-up. Our study showed that there was significant relation between the patient age and their outcome. Higher mortality occurred among younger patients, and that's related to primary HLH as a cause. And the presence of perforin gene mutation increased the mortality risk by 4-fold, and frame shift mutation with insertion mutation, which is considered a novel homozygous mutation, increased the risk of mortality by about 10-fold. And silent mutation occur in older age, while mixed frame shift mutation and missense occur in the younger age. Our findings expand the knowledge about the phenotype spectrum and the prevalence of perforin mutation among pediatric patients with HLH in Zagazeg University Children's Hospital. And my take-home message is that in clinical suspicious of HLH should be released in case of presence of fever, cytopenias, and organomegaly. Early diagnosis and combined treatment can effectively control this life-threatening disease, and the determination of gene mutation are not only a good indicator for predicting prognosis in HLH, but are also an important factor when considering differential treatment. And thank you.